Very good afternoon. The chair, our president, co-chair, I think he's our general secretary. Yeah. And first of all, I'd like to thank Dr. Minu Chaudhary and our team for taking NOS through a wonderful era. And thank you very much for your leadership and your team. And wish the one who coming will be even better. Today, I'm going to talk to you a little bit about future, what we're doing in Nepal, a little bit about past. And let me take you back 3 decades or more. And some of you may not even have been born at that time. Our eye care cataract surgery at that time were done with intercapsular surgery, and patients were given very thick FAK glasses and left with tremendous incoordination. And we found that about 60% of the patients were found without glasses, thus functionally blind. And as much as 6% cause of blindness was due to bad surgery, iatrogenic. And increased complication, fear of surgery, decreased visual outcome were very frustrating at that time. And we, in a small group, went to nooks and corners doing very interesting things such as this one. Here in this picture, you will see us working on a microscope which was assembled at the Balaju Yantrasala, which doesn't even exist now. But Balaju Yantrasala was a very vibrant technical institution at that time. And this was with a Nikon optics and a modem with a bicycle handle, all assembled by Balaju Yantrasala with a jeweler's lamp coming from the site, trying to get a pseudocoaxiality. And we had to rotate the eyeball to get some red reflex here and there. So things were very difficult at that time. You may be interested to see why we are wearing a red gown and a red drape. This was a little surgical outreach in a place called Betravati up in Trishuli. Yeah. And we didn't have enough gowns and drapes. So we had to go and make drapes and gowns in the local area. We went to fish for some clothes in the market. And the only clothes that we could find were these. And excuse me, ladies, these are clothes to make petticoats. So we converted that, and a very nice tailor made them into gowns and whatever we needed in a very short time. Dr. Robinson and we published the very first extra-cap IOL results in a developing country. And this aroused tremendous discussion at the academic pinnacle in the global arena. The who's and who's of ophthalmology sitting in Europe and America started discussing about this topic. And there were lots of people, lots of very interesting feedbacks, but lots of criticism. Many people thought that we are not ready to undertake the surgical procedure of intraocular lens implantation in our country. But I think those criticisms were very helpful to us to move in the future in a proper direction. So there were some inspirations, but lots of criticisms from our own fraternity at that time. Our mission we had very clear-cut mission to provide an initiative to provide sufficient in terms of numbers, successful in terms of quality, and sustainable, high-quality, modern cataract surgery in the community. And we found and studied some barriers, and these barriers were very important for us to document and study carefully, one at a time. The first barrier was surgical delivery, including the surgical technique itself. The team, the quality of the team, the amount of training the team received, and above all, the motivation of the team. This was very important. Infrastructure, making it suitable for eye care work, especially flow of patients and flow of surgery. And we now understand we have got prototypes which we can place anywhere in the world to have such a model. And consumables. Consumables, I like to share this with our younger colleagues. It's very important that you use consumables with good track record. Not all the consumables that you get in the market have good track record. So it's very important. And please use consumables with good track record, especially the ones which you are pushing inside the eye, intracameral. Then you have the equipments. And at that time, it was microscopes. Now you have microscopes, phaco machines, and you have equipments for your biometry, and you have YAG laser and other equipments. The second category of barriers were mostly to do with quality assurance. And we really put a lot of effort in quality assurance right from the beginning. And one important barrier was political will. Everywhere you go, the politicians said, eye is a very small part of the body. We have much bigger issues to handle. So for us to do that advocacy was sometimes very difficult. To talk about blindness in the Ministry of Health. Finance, very important to have a autonomy in finance and have a good finance management, and insurance, of course, now, which is in Nepal, it's coming, but we are also seeing complexity of insurance once it goes into community. And then finally, sustainability. So these were some of the important barriers that we faced. And by and large, cataract continues to be the leading cause of blindness globally. And if you look at this is something that I used to share with my colleagues for many years now. We always talk about the cataract blindness, but we do need to talk about patients visually impaired with cataract. And I talk about operable cataracts. Now, patients as good as less or as good as 6/9 are operated if they have PSCC or some nuclear sclerosis. So I'm talking about operable cataract. And it's believed that 25 to 30 million cataracts are done every year. And most of these cataracts would probably be patients with better vision than the 13 million people. And you know that about 70 million or more still needs to have surgery. And on top of that, the patients that we encounter in the community have very complex cataract. Cataracts associated with other ocular diseases, capsular changes on the cataract, leathery capsules, nucleus, sometimes very large, I call them pregnant nucleus with large bellies, brown, black, and all kinds of cataracts and very friable zonules, often associated with pseudoexfoliation. The WHO in the causes of blindness now says that only 17% of the cataract with visual impairment has access to intervention. And I thought about 6-7 years ago, it was about 20 or 25%, but it appears it's less than 17%. Now, my friends, cataract, as you know, is a very straightforward procedure. Extremely predictable visual outcome, quality almost assured, but in the community, it continues to be a challenge. And if you look at the community, we need to face the challenge of quality assurance, challenge of a proper team, having good stations, and people with lack of screening and diagnosis, and all of these with a good governance, lack of good governance and partnerships. We were able to solve the issue with the intraocular lenses, and we, along with the Oral Lab in Madurai, were one of the pioneer lens manufacturers to bring down the cost of the lens to an affordable range. And so our philanthropic model of reducing the cost of lens has been achieved. And this has allowed a lot of poor people to have access to good quality surgery. Till now, we have sent or distributed almost 7 million lenses to 80 countries. And I think this itself shows the commitment that Nepal has for global blindness. So we started working on adapting a good quality surgical technique. It took us nearly 5 years to simplify, adapt, and test. And then we started globally propagating the training. In 1990s and afterwards, a standard operating procedure developed in Nepal was used by the Fred Hollows Foundation around Africa to train microsurgery. That was the beginning. And the second session we started in Vietnam. So now, with the help of Himalayan Cataract Project, which now is known as Cure Blindness, my friend Jeff Tevin is here. And with the Fred Hollows Foundation, these two organizations' platform, we are training the training around the world. And slowly, we thought modification and application of manual small incision cataract surgery was really the need of the hour at that time in mid-90s, because it was simple, low cost, and the outcomes were great. This is a photo gallery of a very nice friend of mine, which I like so much, to tell you the different states of the surgery of SICS. And then Dr. Jeff Tevin and I thought that the next step for us is to do a clinical trial here in Nepal, because there were lots of criticism about the surgery at that time. This was again in late 90s and early 2000s. And when we started, Jeff and I started giving instruction courses in the American Academy. These courses in the beginning were attended by very few people. Second year or third year, the number of people in third year started so much that we had to change the room. It started to become very popular. Yeah. The clinical trials were done here in Nepal. We invited Dr. David Chang to conduct phaco emulsification surgery the way he does it. And the patients were randomized we found that the examination of the patients and the visual outcome 1 year was comparable in the two techniques, except that the surgical technique and the surgical system of phaco compared with SICS was about 10 times more expensive. Otherwise, the results were fairly comparable. I'd like to show you one video, especially to our young colleagues. And this is a case of, we call it as a hypermature Morgangian cataract. And I call it as chocolate vanilla cataract. You see a chocolate part and you see a vanilla part. And these are the cataracts which have extremely tense capsule, very slippery capsules, and the jonules are extremely fragile. And very often you can land up in complications. And I think it's always nice to put a dye and use the capsulotomy, but I'm not putting a dye. Please, you have to make sure that you have made a capsulotomy. Sometimes you have difficulties in finding out whether you have actually made a capsulotomy. So you can see how the nucleus moves in that large capsular bag. The capsular jonular diaphragm is very fragile this time. I'm putting in a little viscoelastic. Yeah. You can see I'm putting in the lens before the nucleus delivery. The lens acts as a capsular tension ring, putting the capsular jonular diaphragm very strong behind. So you'll end up giving a very safe eye. I wanted to share this with our younger colleagues, especially, that always learn to think out of the box. You never have a strict guideline. Always try to think a little differently, both in clinical, surgical, and management issues. These are post-op results of good SICS. Normally, corneas are very clear, and the modern type of small incision cataract surgery, it generally results in very good results. The use of phaco in community is coming up very quickly now, and I think we have to all at some time talk about it. I feel that cost is important, also good quality is important, and it needs to have a standardized and intensive training program. User-friendly machine, there are so many machines. We have to look at the cost. We also have to look at the user-friendly machine, which can stand all the trauma of the turbulence of power and transportation. And sometimes it doesn't address the issue of large target group. Selection of cases is very important. Ways to lower the consumable cost. But phaco is here to come, and how we take it safely to other communities is up to us. Now, one of the things that Nepal's really done well is what I call stand-alone community eye hospitals. We call it stand-alone community eye hospitals. Big or small, started. The essence is it is always autonomous. And most of the times we take pride in saying that ophthalmologists are in the decision-making chair. I would say in most of these hospitals, and we are in the decision-making chair. We are taking the leadership. And initially, we start with cataract and refractive error. Slowly, we go into community, and then we start developing subspecialties. And a very important thing with such models are the pricing tier and cost recovery model. We make the patients who are affording, make them pay. We subsidize with others and even make it free for patients who cannot pay. But we can do that by subsidizing the cost. And that's what is financial autonomy. And the eye care model in Nepal stands out in the healthcare because we're able to do this so successfully. And of course, quality assurance and good governance is very important. This has been responsible for breaking large amount of barriers in Nepal, and now we are sharing this with many other countries around the world. And the 2000s, in 2000, early 2000, because we were able to provide very user-friendly, low-cost, and high-quality surgical outcome to the patients, lots of patients have started coming to Nepal before we used to visit them, but now they have started coming to Nepal. And for the last 2 decades, I call that as reverse exodus of patients coming to Nepal rather than we going there. And because we've been able to break the barrier, and I'm not sure how long this will continue, I think this exodus is slowly dipping down because there are other organizations, institutions, which have developed on the other side of the border. I'd like to thank my team from Tilganga for being so much with me, Dr. Rita, Dr. Jeff Tevin from Cure Blindness, the Fred Allos Foundation for allowing me to work so much until now. And this is just to show you that we still have a long way to go. The mountain of cataract blindness, I call it. You can see there are hundreds of cataract nucleuses there piling on. And let's try to work together for tomorrow. Thank you very much.